Welcome to UOA On Demand. Today's topic is on PRP, orthobiologics, and injectables. My name is Cris Beiro. I'm a sports medicine surgeon at University Orthopaedic Associates. I'm joined today by my esteemed colleagues and fellow sports medicine surgeons, Dr. Patrick Buckley and Dr. Kenneth Swan. How are you doing tonight, guys?
Hey, Chris. Doing well.
All right. Well, I guess we'll just get right into it. What are orthobiologics? Typically, they're defined as treatments that can positively affect cellular and molecular events and tissue healing. They usually involve cell therapy preparations, and these include things like stem cells as well. Now, these are also in comparison to different kinds of injectables that we can give as treatment options. What other kinds of injections can we give, Dr. Buckley? What else do we treat patients with?
Yeah, Chris, I mean, there's a number of injections that we give patients, and it comes down to a little bit about what you're trying to treat, whether it's a joint or a tendon problem, whether sometimes it's taking fluid out of the area where you're going to drain a knee or aspirate something. A lot of this most commonly would be for knee arthritis. You'd be looking at either a gel shot, a viscosupplementation injection. Very commonly, we do cortisone injections to help get inflammation down and treat pain. And those are used, frankly, throughout the body. And then I think as we're going to talk about, doing a PRP injection or platelet-rich plasma injection or other biologic injections, which, kind of have the potential to both treat inflammation as well as promote healing. Those are kind of the main headings that I talk about with patients as we're looking at kind of non-surgical ways to treat their pain or treat the problem that they come into the office with.
Absolutely. And just to summarize, I guess that tells us that there's different types of injection treatments for depending on what a patient's diagnosis or symptoms are. And that would include steroids, viscosupplementation, as you mentioned, and potentially orthobiologics, including platelet-rich plasma. Dr. Swan, Dr. Buckley brings up a good point. These can be used for many different types of injuries or conditions. Where can we use these injections? What kind of conditions can we use them for?
Well, in our world of orthopedic sports medicine, it comes down to the shoulder and the knee and sometimes the ankle and the elbow. So for patients who have a tendonitis, inflammation of a tendon, or a bursitis, a really acute inflamed bursa around an elbow or a shoulder, or arthritis, which is a degenerative condition around typically the knee, we can use these tools. I think most commonly, many of us might agree that our first tool would be a cortisone injection, which is steroid, and we can use that for these acutely inflamed body parts. It's a strong anti-inflammatory, and it can be used as a form of sort of maintenance of helping the inflammation and pain around these damaged or inflamed joints. And along those lines, the gel injections, also called viscosupplementation, those are only approved by the insurance companies for the knee, although they can at times be used in other joints, such as the shoulder or perhaps the ankle.
Absolutely. So we can use these for a variety of different reasons, as you mentioned, arthritis. We can use them even for tendon or ligamentous injuries sometimes, although we typically don't tend to put steroids in many tendons. I think we pretty much all agree with that, with some maybe little exceptions here and there. Is that correct, Dr. Buckley?
Correct. We tend to inject joints with steroids, but we very rarely inject a tendon. The only major one I could think of would be like a bicipital groove injection, where we inject kind of the kind of area around where the tendon is. But we kind of, the hallmark is like an Achilles tendon. We really don't like injecting them with steroid because you can risk rupture. Whereas other joints, we inject them every day, and we don't have as many of the kind of concerns about injecting a tendon.
Absolutely. And Dr. Swan, I think you brought up orthobiologics as a potential injectable as well. And we see that sometimes they're used for tendon or ligamentous injuries and skeletal muscle damage. They can be used for a variety of different reasons, not just for osteoarthritis in the joint. So I guess moving on to that part of this, what are orthobiologics? And most commonly, we see platelet-rich plasma. That's probably the most commonly discussed or reviewed. What exactly is platelet-rich plasma? Where do we get it from? Where do we take it from, Dr. Swan?
Yeah, so platelet-rich plasma, or PRP, has become relatively popular, and it is a interesting concept that has gained a lot of momentum. Once we learned that platelets in our blood do more than just help us clot when we have a cut, when we're bleeding, they have growth factors on them. And platelets are an important part of the early stages of healing. For instance, when you break a bone, the bone ends bleed, and platelets gather there, and they help form the new bone. So scientists discovered years ago that platelets have several growth factors on or around them, and could we harvest the platelets in our own blood to help heal some of our own injuries or conditions elsewhere? So what happens is, in the office, blood can be drawn from our forearm, just like anytime you go get your blood drawn, and then the small amount of blood is spun in a centrifuge, and the platelet part of it is removed. It's separated from some of the other elements of the blood, such as the red blood cells, and then you can use the platelet component to inject back into the body to help conditions heal, or to help in an anti-inflammatory mechanism.
Right, very good summary. And I think it's important to recognize, in addition to some of those progenitor cells that you sometimes see in those in platelet-rich plasma or other orthobiologics, they do have, or more commonly contain, anti-inflammatory mediators as well as immunomodulatory proteins. And really that's part of the, I would say, some of the main purpose of being able to inject that, is that we see that strong anti-inflammatory effect. At least that's what the evidence has shown us. Moving on to what kinds of PRP, because there are different kinds. There's so many different formulations of PRP, and we'll get to that in a minute as far as why that's a concern. But I think we can all agree that they're broken down into kind of two separate categories in terms of what we call leukocyte-rich and leukocyte-poor. Dr. Buckley, can you explain what that means, and when we would use either one?
Yeah, so Chris, that's a great question to look at the two different types of PRP, leukocyte-poor as well as leukocyte-rich. And this is really where the field has evolved, where we've been, initially looked at PRP, and now we've been able to kind of dial down different parts of PRP and trying to, specifically use things towards the problem that you're trying to treat. So for example, we typically would use a leukocyte-rich PRP, or a PRP that is high in white blood cells. For a tendinopathy, something like patellar tendonitis, we would typically do that. Whereas you don't want to do that where you're going to inject it into a joint, where those would actually promote a higher amount of inflammation and kind of have enzymes that could potentially, not be as effective there. So you would use leukocyte-poor for a joint, where if you're treating arthritis or something like that. And this is where the field kind of continues to evolve, and the ability to separate those out has come to the office, and it's kind of a relatively common procedure and machine, that sits on a countertop that can do that and can give you that ability to really dial in what you're going to inject for the patient based upon their problem. So if they come in with, patellar tendinopathy, you're going to inject kind of leukocyte-rich PRP. If they come in with knee arthritis, you're going to inject leukocyte-poor. And it's a simple button. You just tell the machine what you want, and it can kind of give you the different output based upon what you want to do.
Right. And I think that's an important distinction to make, is that PRP, at least as far as the evidence has shown us, really does help with some of the symptoms of inflammation, but there's very little evidence to really support that they help with functional tissue healing. And so in essence, they can be considered symptom modifying, not necessarily structure modifying. They don't really change or add or heal the condition that you actually have, other than really to get those symptoms away.
Yeah, and I think that was
go ahead.
not what we originally were hoping for or expecting. When we first started learning and studying orthobiologics or PRP specifically, we were hoping it really would, help heal or make stronger constructs out of what we're repairing, whether it's in the OR or just in the office. And so far, we haven't quite figured that out, but it has been shown, as you said, to help some of the symptoms.
I agree, and that's a common misconception. I know I'm sure you guys see it as well. I have a lot of patients that come in and say, Doc, will this PRP help me get better? Will it restore my cartilage? Will it make my tendon normal again? And we have to kind of explain to them that that's not really the purpose of what we've seen with it so far. There are other orthobiologics that do have that potential. I don't know if either of you have any experience with them as far as some of the other orthobiologics, which can potentially contain what we call like connective tissue progenitor cells or mesenchymal stem cells. I know a lot of people ask about that as well. Have you guys seen, either one of you have seen any examples of that or used it in your practice?
Yeah, I mean, I did a fair amount of that in fellowship, and I think this is where I try to really give people like a very kind of balanced, approach to using this type of technology for their symptoms or their pain. I think in general, there's a lot of marketing out there, and patients come in sometimes confused, sometimes getting, frankly, bad information, because the reality is that, these things are not covered by insurance, so they are out of pocket. And I think that, I know that we try to do this very evidence-based and with, that as kind of the foundation for how you're going to counsel somebody. So, we say, look, these have the potential to do this. They're not going to actually regrow cartilage or change that. That's never been shown in the literature, but they still have a lot of benefit, and this might be a really good option for you. But what we're not saying is that this is going to be this way to turn your severely arthritic knee, back 40 years, and you're not going to need to do something, different, right? So I think that's where, having that balance and frankly, that advice from your orthopedic surgeon matters. The other types of, biologics like, bone marrow aspirate or amniotic injections, there's a lot of different things out there that frankly have a variety of levels of marketing, in my opinion, for it, but a lot less science. And, I think if you follow that science to kind of guide how you're going to use this and implement it for your patients, I do a fair amount of PRP because I think there's a lot of good data for it. But to actually go and harvest stem cells, you basically have to kind of take a needle into your pelvis, which is a relatively uncomfortable procedure. And I don't do that in the office, although I've seen it done, in training. And maybe someday we will do more of that. But right now, I think I just kind of follow the data to let that guide me when, the time will be to implement that.
Absolutely. And you bring up a good point. I mean, these are all considered experimental. And the reason being, I think a lot of the literature that we've seen on these orthobiologics either have a shorter term follow-up. They have a very restricted patient or study population that these have been used for. And most notably, there's a really large lack of homogeneity in the preparation of these different orthobiologics, particularly with PRP. And we do see that. So, it's every system or every company that makes a PRP may have a different way of preparing it with different methods, different centrifuge times. The only thing I think that's really been shown to make some of a difference, and even that is still up for debate, is the amount of platelets that are in the concentration of the PRP. But as you mentioned before, there's so much heterogeneity here. It's really difficult to deem this reproducible and therefore still considered experimental and therefore still considered out of pocket.
Totally agree, Dr. Beiro. Especially the early studies, there was a lot of confusion. Back then, we didn't know the leukocyte-rich versus the leukocyte-poor. What if your platelet count is normal but high or normal but low, meaning your normal platelet count for a person can be 150,000 to to 450,000? And what if I draw your blood and it's 150,000? You're not getting nearly the same number of platelets as if it was still normal, but 450,000. So what about the pH? What about the temperature? How long do you spin it for? There's so much heterogeneity in just the preparation of it. And then how are you injecting it? How many times are you injecting it? Are you doing it once? Are you doing it every week for 3 weeks? So the data and the technique was all over the place. And I think it's taken a while, and we are starting to see that there is some data with some benefit out there. But I think the more like mesenchymal stem cell type data is gonna lag behind. That's gonna take a longer amount of time.
Absolutely, great points. So I think there's so much variety in the way these are prepared, administered. Some people give one injection, some physicians may give multiple injections, and we still don't know what works and what doesn't. I think it's also concerning that a lot of these preparations can be done or are done internationally, and we do see other countries. There are physicians that are preparing, whether they're stem cell preparations derived from adipose tissue, bone marrow aspirate, amniotic sources, umbilical sources, and these are injected as well. I'm sure you guys, as well as myself, have seen many patients come into the office saying they've received some sort of stem cell injection internationally or PRP, and some say it worked, some say it didn't, and they ask you to kind of recreate it. It's almost impossible.
Agreed.
Yeah, I see that a fair amount, and I try to counsel people with, look, there's rules, and like the FDA says that you cannot manipulate a stem cell in America, right? You can do it if you have like an investigational trial, but this is why a lot of the athletes go to another country, because they don't have the rules, but also those rules are there to give you safety. And so right now we're going to follow the evidence and implement the treatments when kind of the time comes that we have good evidence to say that they're safe, and then that they're efficacious to treat the problem. And that's the discussion that you're going to have with the person in front of you, really discussing the risks and benefits of using this type of thing. I think we would all agree that putting a biologic treatment for something that obviously needs something fixed or isn't going to help, like if they have a complete ACL tear and we try to treat that with PRP, I don't think that's going to make a lot of sense, and certainly that wouldn't be something that we're going to be recommending. But if you have mild arthritis and there's hasn't responded to other treatments, it's a very reasonable thing. It's got great data behind it that can help people. And that's that discussion where you want to make sure that the person across from you is kind of giving you the the good and the bad and the honesty of it, because as we've talked about, there's still a lot of things we don't know. And I think we all see in the community where maybe it's sold in a different way, and sometimes we have to walk it back and try to tell people, look, this is the reality. It's got a ton of promise. It's probably one of the most exciting things that's coming out of our field in the next, in the last 10 years, and then, as we move forward in the next 10, but there's still a lot to be learned and things we're going to do with this, and that's just where we're at in 2024.
Definitely. I think you hit the nail on the head, that we really need to make sure that our patients understand what the purpose of these orthobiologics are and what they can do for you, and not to really inflate their expectations, so that they really truly understand that what kind of relief they'll be getting from these injections. And just a quick mention about what you said regarding augmentation. So a lot of these orthobiologics can be used for surgical augmentation. To date, I don't think the evidence has really shown any benefit with a lot of common day procedures they're used for. So using PRP for meniscal repair or ACL injuries, while there have been some studies to support these, there have been some studies that don't. So I think really we still need more evidence in the literature to really support whether or not we use them regularly for augmentation purposes.
Agree. And I try to remind people, like, a lot of the reality of those surgeries, like if you're going to do an ACL reconstruction that involves a tunnel into the bone, you get the best PRP you can ever have, which is a tunnel into your bone that has stem cells and bone marrow and PRP and everything right there by your ACL. And so that's free. And so the reality is we've been doing it, we just haven't been calling it orthobiologics for decades. And, you know, adding an additional treatment really isn't indicated there. But there's a lot of times where you can really augment someone's healing. And that's where I think if you follow the evidence and you have a provider, like I know that we all do, who kind of counsels you with that, then this is a really, you know, exciting treatment that, you know, does have a lot of potential to help someone. But you want to ground that with science and evidence, and that's kind of where, you know, I think we all practice as we apply this to our patients.
And I also wanted to ask too, do you do these injections in the office or in a surgery center setting? What's your preferred method? Dr. Swan, just wanted to see what you thought. And are these injections painful if we do them in the office? Are patients going to have some discomfort?
It's an injection, so it's that much discomfort. So it's not that much different than any other injection that we would give, say cortisone or the gel injection. So some people don't feel it much at all. Some people it is a bit painful for, but they walk out of the office and they're okay. But it's an office-based procedure. In my hands, typically it's a one-time thing. So we schedule it. We know that this patient's coming back to the office for this procedure. We allot the right amount of time for that, where we can draw their blood and then inject the area of need. And it doesn't take very long. The whole thing is probably 15, 20 minutes.
It's great. Well, I think the one thing we can all agree on is that different injectables can be used for different symptoms and different conditions, and that even though there's promising literature supporting orthobiologic use and PRP, platelet-rich plasma, there's still further evidence that's needed to authorize widespread use. Just want to thank both of you for all the information and for participating today. Did either one of you have any comments or stories that you wanted to share?
Well, there is one more comment I thought I should include it, and I guess we sort of touched on it, but for the audience, that most injections that we do in the office are covered by insurance. Things like cortisone injections, we can do the day they come in, the first visit they come in, we can do that. We do not need authorization for that. That should be covered by insurance. The gel injections, or what's also called viscose supplementation, and there's many brands of that. Some insurances let us do that right there that day. Other times we have to obtain authorization from the insurance company, and that'll take us about a week to get that. And then the patient comes back and we can do that injection right there in the office. But then, as we touched upon, some of the other orthobiologics like PRP injections are not covered by insurance. So that would have to be, in most doctors' offices, that would be something that's paid for by the patient. And it can be somewhat expensive, and that's one of the reasons why we should not just jump into that as our first line of defense.
Great comment, and that's great information. Again, I want to say thank you to our audience for watching the video. And if anyone has any questions or needs more information regarding this topic, please refer to our website at www.uoanj.com. Thanks a lot, guys.
Thanks, Chris.
Thanks, guys.